Insertion of a peripheral arterial catheter permits beat-to-beat analysis of the blood pressure and access for frequent blood sampling and lab measurements. A simple gel co-cathlon or specialized catheter designed specifically for arterial insertion with an integrated stylet may be used. The procedure is performed using sterile technique. The radial artery is the most common access site to establish an arterial line. The wrist is extended and cleansed with chlorhexidine prep. The index and middle fingers palpate the radial artery without compressing the artery. These fingers are used to visualize the location of the artery. Arterial flashback indicates entry into the lumen. The needle is immobilized while the stylet is advanced into the artery. The catheter is then advanced over the needle into the artery. Proximal pressure is applied to prevent back bleeding. The catheter is connected to the arterial line tubing using a luer lock and secured with a sterile dressing. Blood is withdrawn to remove any air bubbles and confirm vascular entry. A simple cathlon catheter can be used to establish an arterial line. With blood return, the catheter angle is decreased and the catheter rotated off the needle into the arterial lumen. Alternatively, the artery can be transfixed with a through and through puncture. The needle is removed and the catheter is slowly withdrawn until pulsatile arterial flow is achieved. A guide wire is then inserted through the catheter into the arterial lumen and the catheter advanced over the wire into the artery. There are several methods of securing an arterial catheter. However this is done, it is important to maintain sterility. Ideally, the point of insertion of the catheter at the skin should remain visible. Line sepsis is a rare but serious complication. The first indication of line sepsis may be the development of redness at the site of insertion. The diagnosis of line sepsis may be delayed if the point of insertion is obscured by the dressing. It is essential to ensure that the wrist is properly extended. The point of insertion should be close to the radial styloid, as the radial artery will be superficial and immobilized by the wrist extension. A radial artery may be palpated more proximally, but it becomes much more mobile and difficult to catheterize. When vessel entry does not occur within 1 centimeter of insertion, slowly withdraw the needle to the level of the skin and redirect the needle 5 to 10 degrees medially or laterally. If more than a couple of minutes have passed without entry into the arterial lumen, consider changing the catheter, as a clot in the needle may be preventing blood from returning through the needle. If repeated attempts are unsuccessful, arterial vasospasm may have developed, constricting the lumen and preventing needle entry. Consider taking a 10-minute break to allow the vasospasm to resolve. Revisit whether or not an arterial catheter is essential for patient care and consider enlisting expert help. Finally, the arterial waveform should be examined to confirm an appropriate tracing.